Good afternoon and welcome to the CMS public webinar, Quality Counts, Safety Matters, Prioritizing Patient Safety Through Quality Measurement. If you would like to download today's slides, they're available on the CMS MMS Hub, which we will share a link to in the chat. We will also post a recording of today's session on the MMS Hub in a few weeks. Next slide, please. My name is Haley Von Holst, and I work for Battelle, which supports the CMS Measures Management System. Through its tools and activities such as pre-rulemaking, measure developer support, and education, MMS promotes and helps facilitate the development and use of effective healthcare quality measures. I invite you to visit the MMS Hub website to learn more about MMS and how to get involved in quality measurement. Throughout today's presentation, I highly encourage you to submit questions using the Q&A feature near the bottom of your screen. We'll address questions during the live Q&A at the end of the presentation. Following the meeting, we'll create a Q&A summary to answer in-scope questions we couldn't get to during today's session. Next slide, please. We have a great presentation to share with you all today. First, you will hear from patient advocate Precious McCowan about her perspective on how the importance of patient safety to ground today's topic in its real-world impact. Then we will hear from several healthcare experts about efforts to improve patient safety and address preventable harms at the federal level. Next slide. Today, we are fortunate to have 5 presenters: our patient advocate, Precious McCowan, Dr. Michelle Schreiber, the Deputy Director in the Center for Clinical Standards and Quality, Dr. Arjun Srinivasan, the Deputy Director for Program Improvement with CDC, Dr. Reena Dusasia, a Senior Advisor with the Veterans Health Administration, and Dr. Craig Umscheid, the Director of AHRQ's Center for Quality Improvement and Patient Safety. We'll conclude with a question and answer segment. Now I'll turn it over to Precious McCowan.
Hello, everyone. My name is Precious McCowan. I am a mother, a wife, a doctoral student. I am a national patient advocate, and I am a dialysis patient. As a patient with ESRD, this complex journey with the healthcare system began at the age of 9 when I was diagnosed with type 1 diabetes, and at the age of 26 when I was diagnosed with end-stage renal disease. Unfortunately, as a patient with a chronic disease, I am no stranger to hospital visits and numerous doctor's appointments, which of course increases my chances of infections and missed opportunities. On a recent occasion, I suffered from fatigue, hair loss, extremely dry skin, a hoarse voice, low blood pressure, severe brain fog, and rash. Being an advocate for others and myself, I turned to several of my healthcare providers to understand their take or diagnosis of what was happening to me. I even thought that maybe I was allergic to the dialysis dialyzer and the iron medications that I was receiving during treatment. My face and eyelids were very puffy, even after being dried out after dialysis treatments. Each time that I would visit with either one of my healthcare providers, I would express my concerns about my symptoms. After suffering for 3 months, I decided to seek further help by checking myself into the emergency department at a local hospital. Various tests were completed, such as a CT scan and labs. It was then determined that the heart symptoms were from severe hypothyroidism. My T4 blood level test was so low that it was undetected. I was hospitalized for almost 2 weeks, and I wondered, how did my providers miss this condition? Since my diagnosis, my symptoms have greatly improved, and my care team are doing their part to help me manage hypothyroidism. Patient safety is a critical aspect within the healthcare system. Patient safety is more than reducing the risk of adverse events within the healthcare system. To me, patient safety is effective communication, addressing patients' concerns, finding the root cause of symptoms, transparency, and having compassion. As you continue your efforts at making healthcare safer for patients like me, please remember that we depend on the healthcare system to provide resources, medical treatments, and trusting relationships to promote better health outcomes. Thank you to CMS for the invitation to share my story. And thank you to you all for all that you do. Back to you, Haley.
Thank you so much, Precious, for your presentation today and sharing your perspective. With that, I'm going to turn it over to Dr. Michelle Schreiber to continue our discussion on safety.
Welcome to today's webinar on patient safety. Across the federal government, in partnership with our patients, families, and caregivers, and other interested parties, we are all committed to improving patient safety. First, do no harm has been the bedrock foundation of healthcare throughout the centuries. We will soon celebrate the 25th anniversary of To Err is Human. And although we have made progress, we also recognize that harm still occurs too often. Together, from the President's Council of Advisors for Science and Technology to offices and agencies across health and human services and across the federal government to working with others, we are all committed to refocusing our efforts and to make substantial improvements in patient safety. Today, I'm going to cover the CMS strategies for patient safety, and I will be joined by others who will be talking about the strategies in their agencies as well. Next slide. In November of 2022, Secretary Becerra convened a meeting of the top CEOs of healthcare to talk about patient safety and to really emphasize its importance. He opened with a story about, if I were to tell you that more than 200 people were going to die today from medical error, you would say that's not possible. But we all know that that's exactly what's happening. We are essentially losing an airplane full of Americans pretty much every day. And we know we have to do better. Next slide. There were many important lessons learned during COVID, not only around patient safety, but around others. In patient safety, I had spoken earlier about the gains that we had made over the years. However, during COVID, we noticed that patient safety metrics really substantially decreased, and in some cases, eliminated many years of improvement. However, we noticed important lessons of COVID, including the expansion of telehealth capabilities and digital capabilities, rapid scientific advances, expanded collaboration, and yet, in addition to problems with safety, there were stark equity gaps, nursing home care issues, and the need for interoperable data. What this taught all of us is that healthcare needs to become more resilient, including our safety systems. As we rebuild our safety capabilities, we need to ensure that our systems are durable for safety and that they will continue and include continued ongoing improvements regardless of the circumstances. Next slide. Across CMS, we have set a number of goals through the CMS National Quality Strategy. We have 8 goals of the National Quality Strategy, including improving equity, improving outcomes, engaging individuals such as patients, families, caregivers, and other interested parties, aligning our efforts, including aligning across the federal government, interoperability, scientific advancement, and resiliency. And as you can see, our safety commitment is to achieve 0 preventable harm. Next slide. Our target is to improve safety metrics with the goal to return to pre-pandemic levels by 2025, in other words, next year, and reduce harm by an additional 25% by 2030, although our overall target is to get to 0 harm. We have been implementing tracking to show progress, and I'm happy to say that the most recent data does show that our safety metrics have shown improvement. We are expanding the collection and use of safety indicators across our programs and aligning HHS, as you will hear today, with the President's Council of Advisors on Science and Technology to further enhance patient safety. Next. As most of you know, CMS has multiple levers that we use to encourage and enforce the best quality and patient safety, such as conditions of participation, survey and certification, the quality improvement networks that provide direct assistance for quality improvement and safety, multiple quality measurement systems, value-based purchasing programs, payment, and national and local coverage decisions. We are trying to use all of our levers in a united front to improve patient safety. Next slide. The action steps that CMS has taken include the following. There are new performance measures to support patient safety, including new electronic clinical quality measures to cover common safety events. We've done a lot of work on maternal safety and have introduced new metrics for maternal safety, as well as the new birthing friendly designation that was just launched in 2023. There's been a tremendous amount of activity in nursing home safety. We've expanded the value-based purchasing program and have provided a large amount of direct assistance to nursing homes, especially during COVID. In the expanded value-based purchasing programs, we have new areas of safety focus, such as rural health through rural emergency hospitals, opioid safety, such as electronic prescribing of controlled substances, and the expanded home health value-based purchasing program. We're developing a structural measure, especially for the hospitals around patient safety, and we're looking at equity issues when it comes to patient safety and stratifying many of our measures. In addition, we're working across CMS for an integrated safety plan, targeting quality improvement network for specific focus on safety. We released last year updated QAPI guidelines for quality assessment that focus on leadership and governance, especially around safety. We've been supporting interoperability and work closely with the Office of the National Coordinator to make sure that we have appropriate data. And as you know, we have multiple sources of public transparency where we make known to the public our performance in patient safety. Next slide, please. As I mentioned, we have a number of new electronic clinical quality measures that focus specifically on safety, and you can see them here. What's particularly important about electronic clinical quality measures is that they are all payer. They draw from the extensive clinical repository in the electronic medical record. Therefore, the data is more robust, and it can also be garnered in real time so that organizations can use these as real-time trigger tools to be looking at patient safety. Next slide. I spoke of the Quality Improvement Organization. This is a slide of CMS's National Quality Improvement Support for Patient Safety, which includes patient and family engagement techniques, improving internal operational efficiency, support of high reliability organization, one-on-one coaching, quality improvement tools, and sharing evidence-based practices to be sure that we are promoting safety across the quality improvement organizations and across the country. Next slide. The QIO focus of safety has been around end-stage renal disease in decreasing hemodialysis catheter infection rates, in nursing homes to prevent infections, and in hospitals also to prevent infections, pressure injuries. We've been working on measures for sepsis and septic shock, and also adverse drug events such as from anticoagulation and hypoglycemia. Next slide. You'll be hearing today that there's tremendous cross-agency collaboration between the Agency of Healthcare Research and Quality, the Centers for Disease Control, Centers for Medicare and Medicaid Services, Food and Drug Administration, Office of the National Coordinator, and you will also hear today from the Veterans Administration. You'll hear more about this as the session progresses, but I want to emphasize the immense amount of collaboration that has been going on across the federal government and also with our stakeholders such as patients and with other organizations. Through this collaboration, all of us hope to be refocusing on efforts to improve patient safety and ensure that someday we can attain our goal of zero harm. I'd like to pass now to my colleague at the Centers for Disease Control, Dr. Arjun Srinivasan. Arjun?
Thank you so much, Michelle, and such a pleasure to be with all of our partners today to share a little bit about the federal collaboration. Next slide, please. As Michelle mentioned, there is a lot of work that's being done here to collaborate across the groups, and I'm going to really focus my comments today on ways that we can use measurement to support prevention. Next slide, please. It's a great saying in public health and quality improvement that what gets measured gets done, right? Our patient safety successes, some of which Michelle talked about over the past several years, included some really significant pre-pandemic reductions in healthcare-associated infections and antimicrobial resistance. For example, we saw that central line-associated bloodstream infections had decreases that approached 50% over a 5-year period before the pandemic. Also saw reductions in catheter-associated urinary tract infections and some modest reductions in surgical site infections. And on the antimicrobial resistance front, we saw reductions in things like methicillin-resistant Staph aureus, Clostridioides difficile, carbapenem-resistant Enterobacterales. So really across the board gains and advances in safety, not as much as we would have liked. We would love to see all of this resolved completely, but we were making some really important progress. Next slide, please. And I think one of the things that underlines a lot of that common progress that I just noted is a common system for tackling these issues. And a lot of people have pointed out that one of the keys to success when we think about our ability and our successes in healthcare-associated infections and antimicrobial resistance has been the fact that we have a long-standing, dedicated monitoring system with very well-established definitions along with dedicated expertise. And they say, that kind of support at CDC has really been foundational to our successes in reducing healthcare-associated infections and antimicrobial resistance. And that system is really important, right? The system that we're talking about here is the CDC's National Healthcare Safety Network. It's in place at more than 35,000 healthcare facilities of all types around the country who are regularly using this to report safety events. And I think that type of familiarity is incredibly important, and it's something that we should capitalize on. Next slide. But it's important to note that the National Healthcare Safety Network is not just a reporting platform. Really, it is kind of the way that the agency uses and uses data to inform our prevention system, right? It is embedded within our division, the Division of Healthcare Quality Promotion, embedded in CDC, and it's supported by a team of experts. And this is not just folks who have deep expertise in analyzing healthcare safety data, which we do have and which they do, but it's also supported by a team with extensive expertise on investigating, researching, and preventing these bad outcomes, healthcare-associated infections and antimicrobial resistance. And it's that construct, it's the embedding of a measuring system directly within the expertise that helps prevent those infections that I think has been so successful and has really helped us make this progress, because the data can inform the action, and then it also allows us to know if these actions are working. Next slide, please. So we know, and Michelle's already mentioned, right, with the growing power of electronic health records and the ability to be able to securely share healthcare data through things like the Fast Healthcare Interoperability Resources, or FHIR, it's really allowing some transformative advances in safety measurement, right? It allows us to think, how could we expand event reporting in ways that we never could have conceived of before, because it was way too burdensome to do this manually. And when we think about expanding that data collection, it's not just better ways to collect the outcomes that we're already measuring, but it's expanding that data collection to allow us even to think about the collection of ancillary additional safety measures that we're not even thinking about right now. And it will allow for way more sophisticated and detailed risk adjustment to be done. And that's always one of the challenges. We want to use risk adjustment to help us adjust so that the data are most actionable. And this change to electronic reporting and digital reporting, I think, is going to facilitate just that type of advance. Next slide, please. Just as an example, so thinking about what we measure right now, right? Central line associated bloodstream infections, major area of success, something that we're very proud of. A lot of good work has been done in this area, but a lot of experts point out, hey, a lot of people get bloodstream infections in hospitals that are not just related to their central lines, but those might be preventable too. One of the biggest examples that we hear about is, what about all of those infections that are due to peripheral intravenous lines that may not be inserted or cared for properly? So electronic data would allow us to change that construct and think about reporting of all hospital onset bacteremias. We could get that information electronically, and then in so doing would allow us to think about other important balancing safety measures. For example, how often might these blood cultures represent contamination during collection, because they're organisms that likely represent contamination. So it's an expansion not just of the primary outcome, which is the move from central line associated bloodstream infections to all hospital onset bacteremias, but expansion to these additional important safety measures like blood culture contamination. Next slide, please. So what we are doing in this area is working to take these steps informed by extensive partnership all the way through, right? And this is with across the federal government, it's with academic partners, with prevention experts, because there are so many key steps, right? We have to develop definitions that are clinically important. We want people to see what we're measuring and see the importance of what we're measuring. We have to assess all of the risk adjustment options. With more data come more opportunities for risk adjustment, but we have to understand what is the best way to approach that type of risk adjustment. And then I think, most importantly, we have to work collaboratively in order to test these new measures to see if they are going to respond the way we think they will to our prevention experts. I think we'd all agree that a measure that doesn't respond to an intervention is not a useful measure. Next slide, please. So what's next? What are the steps that we're taking? Well, we're already moving in this direction and in close collaboration with CMS, right? So we have some FHIR-based measures for both hospital onset bacteremia and Clostridioides difficile. The Clostridioides difficile measure combines a positive test with something that's lacking now, and that's a decision to treat that test. And we've heard from many clinicians that, hey, if you can pair that test result with a clinician's decision to treat, people will really think that that measure is much more clinically meaningful. We're also working on an electronic and then a digital quality measure of sepsis. This is an outcomes measure for sepsis, so important, something that's been emphasized for so long. We're taking some really important steps in that direction in very close collaboration with CMS. Next slide, please. Then transitioning those, we start to think about the slightly longer term. We're collaborating with CMS and thinking about how NHSN might be used to support and inform the reporting and prevention of non-infectious harms, right? There's nothing unique about infections in this space. The same rules that apply to the things that we've been able to do so successfully on healthcare-associated infections could certainly apply to non-infectious outcomes. So we've started thinking with CMS, how might we develop FHIR-based measures for things like glycemic events, deep venous thrombosis, opioid-related adverse events, and kidney injury in hospitalized patients, all the types of things that Michelle has told you CMS is already well advanced in working on. And we're now thinking about how do we create digital measures, FHIR-based measures for these. And we want to work with CMS and with all of you to think about how we take these next steps to develop these measures and bring them into the community to test them for their prevention, to test them and see how well they work for prevention. Next slide. And in the longer term, we're really starting to think about, what are the types of things that we're not measuring at all right now? We're not able to measure. It's too burdensome, or we don't yet know how to approach it. And let's think about electronic native measures for those, right? So measures that are built right out of the gate to be FHIR-based measures, digital measures, without any kind of manual reporting first step. And I think that part of the challenge there is we have to start thinking about how to measure that harm. There aren't good definitions for things like pediatric sepsis in pregnant patients. And so we have to start thinking about those to inform that future state of these electronic native measures. Next slide. So I'll close there and just say, I think, with electronic reporting and FHIR technology, we are approaching this new day. It's not here yet, but it's coming soon, when the burden of reporting is not going to be the primary challenge that we face. So, but with that expanded capacity, I think comes even more responsibility for all of us, right? How do we collaborate to ensure that we have a well-developed prevention portfolio so that we've not only got the measures, but we have the corresponding prevention activities that go along with actually working to improve those measures? And how do we collaborate, just as importantly, to ensure that those prevention measures are implemented effectively and equitably? And I'll just close by saying this is one of my favorite sayings, that measurement without prevention is just counting, but prevention without measurement is just guessing. And with that, I'm going to turn things over to my colleague from the VA, Rena Duzasia.
Thank you, Arjun. So my name is Dr. Rena Duzasia. I'm Senior Advisor in the Veterans Health Administration and the Office of the Assistant Undersecretary for Health for Quality and Patient Safety. For those who are not familiar with the Veterans Health Administration, it's the largest integrated health system in the United States, and it consists of about 170 inpatient facilities, which ranges from small rural hospitals to very large, complex academic medical centers in urban areas. And many are actually affiliated with teaching hospitals and medical schools. The Department of Veteran Affairs is actually the second largest agency in the federal government, and the Veterans Health Administration, where I sit, is the largest part of that department. Next slide, please. High reliability organizations, share a collective mindfulness. And what I mean by that is that we realize that even small failures and processes can lead to catastrophic adverse outcomes. But when they're caught early, these small problems can be easily fixed. So the concept of a high reliability organization was actually pioneered in the nuclear and aviation industries. And then it was adopted in the 1990s by healthcare systems. And early adopters included the Joint Commission as well as the VA with the National Center for Patient Safety. The National Center for Patient Safety, actually established in 1999 here in VA, is going to be celebrating its 25th anniversary this year. Next slide. High reliability is an organizational transformation that requires everybody's participation. As I mentioned, VHA was on the forefront of patient safety science back in the 1990s, and then undertook a major recommitment back in the late 2018, early 2019 timeframe, when we decided to pursue what we now call high reliability organization principles and methods. The journey for the Veterans Health Administration has unique opportunities compared to other health systems, given the size and complexity of our largest healthcare system in the nation, as well as the considerations required for veterans' care, in addition to legislative requirements and community partnerships, which require the VHA to operate in a complex and high-risk environment. Next slide. So if we ask the question, what are the hallmarks of a high reliability organization? We can look at the pillars, principles, and values for that answer. The three pillars that VHA has adopted include, as you see in the slide, leadership commitment, culture of safety, and continuous process improvement. And this is really the cornerstone of which VHA has built its strong practices. Leadership commitment means that high reliability is reflected in the leader's vision, decisions, and actions. A culture of safety indicates a workplace where safety values and practices are used system-wide to prevent harm and learn from mistakes. As part of this, the Veterans Health Administration fosters a culture in which our staff members feel both physically and psychologically safe. And third is the continuous process improvement pillar. This refers to an organization whose teams use effective tools for continuous learning and improvement. I'll illustrate this latter pillar later with some metrics. At VHA, we've also adopted a framework that promotes 5 principles and 7 values, as you see on this slide. Our 5 principles teach us how to practice high reliability in our daily work, and our values unite us and guide our actions and decisions every day. Next slide. So how does the Veterans Health Administration advance this journey to high reliability? On this slide, you actually see 6 enterprise-wide activities that the Veterans Health Administration has adopted across its 170 medical centers and its clinics. The 3 activities that started together across all hospitals at the same time are listed here include the AHRQ baseline training, continuous process improvement, and experiential learning. And then the remaining 3 activities listed here are actually cohort-based, and that includes team training, HRO assessment and planning, and HRO leadership coaching. Next slide. I wanted to illustrate how this becomes action for us within the Veterans Health Administration. The Joint Patient Safety Reporting System is a voluntary system that we have adopted that allows for any employee to report any patient safety event within their front line of care. It's a tool where, we really encourage employees to voluntarily report what we call adverse events and close calls. Adverse events are defined as untoward diagnostic or therapeutic incidents, any iatrogenic injury, or any occurrence of harm that directly is associated with the care or services delivered by VA providers. And then the second one is close calls, which are events or situations that could have resulted in an adverse event, but did not, either by change or through timely intervention. On the right side of the slide, you actually see over the last year, our ratio of close calls to adverse events. And you can see that over time, especially in this last year, this ratio has indicated that close calls to adverse events have been positive, which is actually an indicator of how well our HRO system is doing. Next slide, please. So we also added patient safety culture questions in our all-employee survey, and this started in 2018. And this slide actually reflects some of the promising results in their journey for high reliability efforts. Under leadership engagement, we've seen a steady increase in the positive response to the question, I have trust and confidence in my supervisor. And this indicates that we are moving toward a just culture within our enterprise. Second, Stop the Line is a marker of patient safety, and measuring it shows us staff members feel that they can speak up if they see something that may negatively affect patient care. Year after year, we are also seeing improvement across our cohorts in this metric. And lastly, as I mentioned, as we're seeing patient safety culture grow, we expect HRO facilities, that have adopted this principles to see an initial increase in reporting of adverse events, and then followed by an increase in reporting of close calls, until eventually we would see that the number of close calls outnumber the adverse events. And as I showed in the last slide, we're now seeing close calls now outnumbering adverse events. Next slide. So the next few slides, I want to actually emphasize the third pillar of HROs, which is the emphasis on continuous process improvement. As you can see, VHA is committed to continuous process improvement, and we actually measure that impact on our performance. This slide indicates several metrics and particular process measures and how we evaluate after implementing processes across facilities. How does the data actually, translate to the actions of trying to improve care processes on the front line? And as you can see for a number of these that we were able to track, that we are seeing gains in improvement. Next slide. With regard to healthcare-associated infections, I also want to share a few examples. The Veteran Health Administration started its focus on improving CLABSI actually in 2006, before we've adopted and renewed our emphasis on high reliability, as I mentioned, in 2018. I think this trend graph is actually really important to see. Here, a few key points. VHA experienced a huge decrease initially when process improvement processes were put in place. But sustaining improvement includes not only education and reviewing routinely the data, but recognizing that there can be spikes in data, which leads to another inquiry of processes and to identify other opportunities to improve care delivery. Next slide. On the next slide, you can see that for CAUTI, VHA started this journey actually in 2011. And in similar trend lines where the process improvement efforts were employed as here, I want to note that in this slide and the last one, it illustrates that Black sliding is a real risk when there's a stress to the healthcare system, like we all experienced during the COVID pandemic. It also illustrates the difficulty to get to zero infections when addressing like the low-hanging process improvement opportunities. And lastly, in the next slide, I want to emphasize our efforts around the SEP1 composite bundle. Next slide, please. We are seeing actually with the implementation of the SEP1 composite bundle in the last 3 years, a decrease in the 30-day standardized mortality. So the increase in compliance of this early management bundle is actually showing tangibly across our veteran population a decrease in the 30-day standardized mortality. So with that last example, I'd like to turn it over to my colleague, Dr. Craig Umscheid from the Agency of Healthcare Research and Quality. Thank you.
Thank you, Dr. Duseja. It's a pleasure to be here today presenting with my colleagues from the federal government. I was asked to speak about the National Action Alliance for Patient and Workforce Safety, which AHRQ is helping to stand up along with our federal partners. Next slide. As Dr. Schreiber described at the start of this webinar, Secretary Becerra had a call to action in the fall of 2022, along with healthcare system leaders, to recommit to patient safety. And this was in the wake of the COVID pandemic when safety events were increasing. In January of 2023, our agency on behalf of Health and Human Services put out a request for information to the public to understand how the federal government and HHS particularly could best help the public and healthcare systems with advancing patient safety. In March 2023, AHRQ's National Advisory Council, which is our board, charged a subcommittee with coming up with recommendations to fuel what we were calling a National Action Alliance for Patient and Workforce Safety. That subcommittee met in the fall and provided us with its final recommendations in December. And we've been working to operationalize those recommendations over the last 2 months. Next slide. These are the 5 aims that have come out of this report. And these are the 5 aims of the National Action Alliance for Patient and Workforce Safety. And we're going to take a few moments to go through each of these aims to explain them in some depth. So the first aim is around advancing healthcare organizational safety strategies using the National Action Plan foundations. Now, for those of you who don't know the National Action Plan, this was a National Action Plan for safety that was put together and released in mid-2020. The timing was not great because it was in the middle of the start of the COVID pandemic, so it didn't get the attention that it deserved. But the report was co-chaired by IHI and AHRQ, along with our federal partners and about 30 organizations nationally. And it defined what the foundations were for an organization succeeding in patient safety. So for this first aim, we're asking healthcare organizations to make a commitment to patient safety and recommit to patient safety and perform safety self-assessments based on this National Action Plan foundations, and to use the gaps that they've identified to strengthen their safety strategy across the organization. So you see in this figure here that that's the overarching aim in this figure. The second aim is empowering the patient voice in the safety strategy. And there are a number of ways that organizations can do this, from having patients submit safety events directly, including patients and families in event review, and getting their input on the development of safety initiatives, and also organizations embracing communication and resolution programs. And this is pictured here in the figure by the patient in the middle of the figure. The third aim is healthcare safer by design. This is represented in the figure by the electronic health record. And the goal here is to identify, address 5 high priority safety engineering needs and integrate those and engineer those into technology directly. The fourth aim is to strengthen safety competencies. This is about developing safety competencies, adopting them, and reporting on their adoptions. And this isn't just about safety officers across a healthcare organization. This includes the entire healthcare team, from the board to the executives to the clinical staff and non-clinical staff. And this is represented in the figure here by our healthcare providers. And the last aim, which is at the foundation of this figure, is establishing a learning and research network that can provide a scalable bundle of safe practices, learning and sharing across the network, the ability to spotlight change leaders, promote robust system and national measurement, and research to address high priority needs. Next slide. The National Action Alliance builds upon the foundational elements of the National Action Plan. And for those who are less familiar with the National Action Plan, we have the 4 foundational elements here. And if you were to do a self-assessment based on those 4 foundational elements, these are the types of assessments that you would be asking your organization. So for the culture, leadership, governance foundational area, does your organization have safety goals with identified champions? Do leader annual reviews incorporate safety? Are there regular safety culture surveys across your organization? For the patient and family engagement foundational area, are there actively engaged patient and family advisory committees? Are shared decision-making tools or patient portals used widely? Does your organization analyze safety data, not just at the organizational level, but using an equity lens where you look at your safety performance across particular patient cohorts to identify areas where safety needs to be particularly strengthened? For the workforce safety domain, does your organization have explicit worker safety strategy? Does it employ occupational safety experts? And lastly, for the learning healthcare systems foundational area, are there defined safety education and competencies for all workers across your organization? Does the organization regularly participate in learning networks? Next slide. So this is how we're organizing to achieve Alliance aims. And this is in partnership with our federal colleagues, particularly our colleagues in Health and Human Services, but also our colleagues outside of Health and Human Services, including the VA and others. So the first thread that we're acting on in this first year is really focusing on healthcare provider organizations and encouraging organizations to commit to the safety self-assessment to inform their safety strategy. And we'd like to recruit high-performing organizations across the nation to serve as change leaders in our Action Alliance. And we have a number of potential partners that we're hoping to work with in this effort. The next thread you see on this slide is convening an engineering safe practices group, where we can identify high priority opportunities to further engineer safety into technologies used in healthcare. And you can see some of the potential partners that we've reached out to or are planning to reach out to in the coming weeks and months. And lastly, the Safety Science Competencies Group. This is another group that we're planning to convene where we can engage partners on curriculum development, education, training, and accreditation. And you can see the potential partners that we list here. Next slide. The plan is to engage the National Action Alliance engine to power the vision of this alliance, which is safe care everywhere, zero preventable harm for all. And Dr. Schreiber alluded to zero preventable harm as a primary safety goal for CMS at the start of this webinar. So how does this engine get turned on? Well, it starts with healthcare organizations identifying needs through baseline safety self-assessments. And then based on those needs, healthcare organizations can access and engage with the National Action Alliance engine, which provides national webinars. It supports implementation initiatives across healthcare systems in the US. It provides tools and resources on how to address safety. It provides funding opportunities and provides measure sets and safety dashboards. And the idea is that use of this National Action Alliance engine and engagement with this engine can help learning healthcare organizations learn from each other, identify and implement best practices across their organization, have safety science research supported in their organizations, and this activity is aligned with value-based purchasing and value-based care. And the hope is that by 2026, these activities can reduce harms by 50% from the peak of the safety events that we saw in the pandemic. Next slide. This slide shows just some examples of select tools, funding opportunities, and implementation initiatives from AHRQ specifically, and it's organized by the 4 foundational areas of the National Action Plan. So for example, in culture, leadership, and governance, AHRQ supports surveys on patient safety culture, which your organizations can use to assess culture and measure improvement in culture. For patient and family engagement, AHRQ supports the Team Steps 3.0 tool, and we're currently beginning recruitment for an implementation initiative where we're training healthcare systems on the new version of this tool within their site. Candor is another tool that we help support around communication and resolution, which is directly relevant to patient and family engagement. For workforce safety, AHRQ has a new funding opportunity. It's an R01, looking at systems-based approaches to improve patient safety by improving healthcare worker safety and well-being. And this funding is up to $2 million over 4 years. And lastly, for the learning healthcare system foundational area, AHRQ has many learning healthcare system tools, including AHRQ PSNet, which is a one-stop shop for patient safety information, and measurement tools like Calibrate DX, which is a resource to improve diagnostic decisions. It's a tool, but it's also part of an implementation initiative that we'll be recruiting for in the fall to help pilot new diagnostic safety tools across the US. Next slide. We also have a national healthcare safety dashboard that we're standing up. And this is a dashboard that over time, we hope is able to cover all of the different healthcare settings across the US. In this example, we're looking at hospitals in particular. We're looking at patient safety indicators, and we're measuring a particular patient safety indicator, postoperative sepsis, and its change year over year. With these types of tools, we're also able to stratify our measurement by variables like patient race. And so you can see that in this tool. If you click the state data button on this tool, next slide, you can look at performance on these measures by state, and you can see those states that are performing at the highest quartile versus those states that are performing at the lowest quartile. Next slide. So we're excited about standing up this National Action Alliance for Patient and Workforce Safety with our partners here on this webinar today. And we urge you to commit to the National Action Alliance for Patient and Workforce Safety to join us. The commitment is here on this slide. You could go to the next slide as well. And the commitment is also available on our website. The National Action Alliance website serves as a hub to engage, and you can not only find the commitment, but you can find information about webinars, other opportunities to identify safety tools and safety initiatives that you can engage in, and also opportunities to do safety self-assessments at your organization. Thanks for the opportunity to present today.